Hi everyone. Sorry, we've just had some technical difficulties, but we've just started the talk now. We've got GI pathology with Dr. Aiden Moore.
Good evening. Thank you very much for giving me the time out of your evening to come and hear me talk about pathology. I've kept my camera on just for now so you can see my little preview and put a face to a name, but I'm on a double screen, so my lecture is on this computer here. So I'll probably turn my camera off so it doesn't look like I'm awkwardly turning away from you. So in terms of what we're going to cover in this talk this evening, this is a talk that I gave last year that Stephanie asked me to give again this year. Obviously, some people seem to enjoy it, which I'm glad about. My background is in surgery prior to joining pathology, and this talk was made much earlier into my career when I was just transitioning over. So it kind of focuses on how surgery and pathology go hand in hand, where there's a nice overlap of knowledge that benefits pretty much everybody in medicine, before taking a look more into specifically lower GI and upper GI pathology. So please feel free to put any questions in the chat. If I see anything that I can answer as I go along, then I will, but I'll try and probably save most of them to the end. If there are any issues, just let me know. So I'll turn my camera off and I will carry on with my talk. So this talk is going to be about surgery and pathology. Both of those things are very closely linked and go very hand in hand. Much of our workload in histopathology comes from our surgical colleagues. But we do get a wealth of specimens from across every specialty, community and hospital based. So it's a wonderfully broad specialty that I am thoroughly loving working within. So I always think these talks are a nice little way to display exactly what background people come from to get where they are at the moment. And sometimes it's quite nice to see the diverse places that people come from or the circuitous routes they've taken to get where they are. So in terms of my background, I'm originally from Yorkshire, and that's where I grew up before I then went to medical school. So I went to the University of Manchester through 2012 to 2018. And if any of you have been around the Manchester area, you'll probably recognize that archway from within the university campus and just next to the museum. That building is where I have my graduation ceremonies. And then I went on to go and do my FY1 and FY2 years over in the University Hospital of Wales and its adjacent centre, Llandoch Hospital. I had a really good time there before I went back up to Manchester, and I worked in Manchester Children's Hospital in paediatric surgery and their neonatal intensive care unit. Had a wonderful time seeing some really rare and wonderful conditions there, which prompted me to undertake surgical training back across the Yorkshire region, before I kind of learned through myself that actually what I desired more was looking down a microscope and making the diagnoses rather than just cutting bits out and sending them off to pathology and finding out what the answer was in a report. And that journey was quite literally not linear. It took me up and down and left and right, but as it is at the moment, I'm based over in the Merseyside deanery for at least the next 4 years. I'm currently ST2, depending on other things that I want to take and do. And that's great, and that's fine. And you'll find in histopathology, there are lots of pathologists that have gone through different areas of their career before settling into histopathology, as well as people that have gone straight through without any breaks or stops. In my office at the moment, we have one ex-clinical biochemist, we have one doctor from Ethiopia that was practicing there for a few years, and another that came straight through from F2. So we're a nice varied bunch, and that very much adds to the wealth of knowledge that we have as a trainee group and a departmental group. So you guys have probably heard a fair bit about surgery and surgical applications, and given the current state of applications and competition ratios, these slides probably haven't aged terribly well, but hopefully you'll still appreciate that the points I'm trying to get still stand. So surgery as a career is a competitive application after foundation training with many diverse subspecialties that you can enter once you complete core surgical training. You enter into a bunch of acute and critical scenarios, and there are some intense demands that come with it in terms of on-calls, much like our medical colleagues experience. I found that the thought process in there was quite nice to follow. I have a very structural brain, so it made sense. If there's something that isn't meant to be there, if we can fix it, then we'll fix it. If not, then we'll just get rid of it and we'll send it to pathology to figure out what it is. In contrast to histopathology, it is also a competitive application, more competitive now than when I applied, which was still considered competitive historically. But in a similar way, it is also full of many diverse subspecialties. So although at the minute I'm doing histopathology, I can choose to subspecialize in pediatric and perinatal pathology, specifically looking at children and the conditions that they encounter. I can subspecialize in neuropathology, specifically looking at the brain. Forensic pathology, where it's more post-mortem based. There is the legal aspect, working with the Home Office into suspicious deaths or murders, and pursuing academic routes via research. So it is a wonderful and diverse specialty in and of itself. And the thing that I love about it is that your every single day is full of the weird, the wonderful, and the exciting. All the stuff that you read about in the textbooks that comes upon your exams, you see in real time and in real life. And the personal thing that makes a big difference to my work life is that the work-life balance of the job is much better. So I would fully recommend it from all avenues and all perspectives. You will find as you progress through your specialties that there is a massive link with histopathology no matter what you do. My own experience from surgery, I won't expect you to read all of this, but it just highlights the fact that histopathological knowledge is expected across the surgical curriculum. When I was doing my surgical exams, I had to learn about the cytological features of malignancy and benign tissues and how to categorize different malignancies and oncogenic processes. And that was what developed my interest in histopathology. And it's always interesting thinking about how people don't think that that knowledge exists outside of histopathology. I've kind of covered all of that, so we shall move on. I suppose this just kind of highlights that actually there is a stereotype that histopathologists are alone and working within offices away from everybody else, but we do form a part of the MDT, and you get to have some wonderful discussions with our radiological and clinical and oncological colleagues about the best way to manage these patients. Histopathology, as you'll come to learn through this talk, is a fundamental part of that. So with my own personal journey and my own personal career plug over and done with, let's get to the meat of why you guys are here. So we're going to go through 3 cases. These are going to be a similar setup to some of your exam style questions. The idea is to get across the clinical correlation and the clinical significance of why histopathology makes a difference. So some of these things, hopefully you'll be able to follow through and then learn some interesting histology through the process. So case 1, a 67-year-old man is seen by his GP with a history of increasing fatigue. On further questioning, he reports that he's had some intermittent diarrhea over the last few months and he's needed to go down a few loops on his belt. Routine blood tests show the following, and very helpfully, I have highlighted the significant abnormalities there. So we've got a low hemoglobin and a low MCV. What would the next best step be? If any of you are confident to put your money where your mouth is and let me know in question form or chat form what you think the answer might be, I'll give you about 20 seconds or so. Okay then, so from this clinical vignette, what we're trying to get at here is that this patient has anemia and they have some concerning symptoms whereby they've had to go down a few loops on their belt. So they've got weight loss and we have intermittent diarrhea. So we've got some GI symptoms going on. So the most appropriate thing in this circumstance would be to do a colonoscopy. And on colonoscopy, down the camera, inside this person's bowel, this is found. Now, if any of you have ever seen these before, you'll know that this is a polyp. We'll go on to discuss polyps right now. So polyps, something that gets mentioned a lot at medical school, but something that you don't often actually get taught about. So a polyp in its most generic sense is an outgrowing of tissue from a mucosal covered surface. So you can get polyps in various different areas of the body, and these are described by the location that you find them. So obviously you can't make a better diagnosis than that until you get it under a microscope. So you can have polyps in the stomach, which are gastric, and the duodenum, which are duodenal. You can have bladder polyps, you can have esophageal polyps. Anywhere that you find a polyp, you just name it for where it's from. If you're able to take it out, then you can take it out and we will make a more formal diagnosis under a microscope. But importantly is the morphological appearance. In other words, the appearance as it looks, both inside the person's body on the endoscopy camera and also to us in the lab. Now, when we receive it in the lab, we tend to get quite a scrappy little bit of tissue. So having images like this is actually really helpful because we can see exactly what the shape of the polyp is, if it's got any abnormal vasculature to it, and if it's regular or irregular. And all of these things help to build up a picture of broadly whether we think this is benign or malignant, which is ultimately what we try to gather from these things to strategize what happens to these patients next. And why is that important? Some polyps can be pre-malignant. If we get them out early enough, that's great. But if we don't catch them in time, then after that, obviously, they can become malignant, they can become invasive, and that can then prompt further investigation. If we have a sample from a very highly aggressive looking polyp, it might prompt further investigation to guess whether this person has an actual cancer or not. But in order for us to make some sense of that, we do have to take a step back and look a little bit at GI tract microanatomy. So these are things that you'll probably have covered in your first 2 years of medical school when you were doing your anatomy and physiology, things that may have drifted out of your head over time, but that's not a problem because on the left-hand side of the screen, there is a brief diagram there that takes you through some of the broad layers working from the inside to the outside. We have the mucosa, covered with our epithelial cells, the ones that just get sloughed off over time, but also act as a vital barrier and a vital area of exchange as food and nutrients are absorbed into the blood across that mucosal barrier. Separating that mucosa out from the underlying submucosa is a small muscular layer, a muscularis mucosa, leading into the area where all of our glands are, all of our blood vessels and lymphatic tissue, before we get to the muscular layers that do all of our peristaltic movements. And why is all of that important? Well, again, we need to be able to look at these things to be able to know if there is an abnormality, where it is within the bowel, and if it's invasive, how far it's invading. Now, the image on the right-hand side of the screen is the histology from a portion of large bowel. So the image on the left-hand side, this is basically what it looks like in real life. Now, everything that we look at down a microscope is stained as standard with two things, hematoxylin and eosin. What that means is that everything comes in shades of pink and purple. So all of your nuclei will stain up in a dark purple or blue color. A lot of the intervening tissues will stain various shades of pink and purple and those in between. And it's the experience of looking at these time and time again that allow us to characterize exactly what tissues are. So if you go with me on this brief description, on the right-hand side of your screen, where you can see that you have got labeled mucosa, you should be able to appreciate and see, hopefully you can see my mouse, that we have these invaginations in this mucosal layer as these crypts, that we call them, these glands go up and down, providing a greater surface area along the bowel. And these small grayish blobs that you can see, these are the goblet cells that produce mucus into the GI tract lining to help to lubricate everything as it's going through. Below that, or deeper to that, we have our mucosa, where you can see some little red speckled dots inside a pink circle. That's a blood vessel. Then we have our muscularis layer, which is lovely and pink, with our streaky, we say spindled nuclei in layers as they are muscle fibers. And then we have our serosa on the outside. So that is a really, really quick whistle-stop tour just of what we're looking at. I want you to try and have that in your mind, and we will take you on a little bit of a journey. So normal bowel mucosa, kind of as I said, We have crypts rather than villi. If you remember that villi are those little sort of tendrils that are exophytic and branch out. They increase the surface area and allow for absorption in your small gut. In your large gut, we have crypts that go down. And the typical appearance that is described in the textbooks is that it looks like a rack of test tubes, where you've got these crypts that dangle down. They look like the glass test tube. And as they're as they're laid out in parallel next to each other, they form a test tube rack-like appearance. So what we're looking for is that these things are regular and straight and even. And those are signs of normal architecture. Whenever we talk about things under a microscope, not only are we commenting on the individual cells, we're also talking about their actual arrangement. So you'll hear these words used quite a lot in histology: architecture as well as morphology. Morphology meaning the way that things actually look, the individual cells, the cytology, and the architecture, the way that everything is arranged. And what's really important to appreciate is a little bit like if you've ever had CT scans explained to you or any radiological imaging, you're looking at a 2D picture of a 3D structure. So we have to appreciate that we're only looking at it from one perspective. Depending on the angle that we look at it, we may get different shapes produced. So being able to recognize these things in multiple different views is actually quite important. So you can probably see that the image on the bottom of the screen is different to the image on the top of the screen, but they're actually the same thing viewed from different angles. And if you think back to what I was saying about these things being little test tubes lined up, if you're looking at that test tube rack from the side as it's sat on the rack in front of you, and you can see the glass tubes dangling down. If you take that test tube rack and you look at it from above, like, if you're looking down it, like if you're a bird flying over, then you'll be looking down and seeing inside these glass tubes. And that's exactly what we're seeing on the top of the screen. Rather than seeing long tubes hanging down, we're seeing the circles of these tubes as we're looking into them, looking down the lumen of these crypts. And that's just two views of the same structure. This image is just highlighting a little bit more detail, everything that I've just been talking about. And what I want you to take away from this is an appreciation of what normal can look like. The staining quality of this is a little bit different. Some of these things look a little bit darker blues, more aggressive pinks or purples. But when we actually look at this image and take a step back from how aggressive some of these colors are, what we can see is that these things are all regularly laid out, relatively evenly spaced, and there's nothing that stands out as being particularly, well, I would say particularly abnormal, but basically anything that just looks like it shouldn't really belong there. And in the most early days of histopathology, when you're starting to look down a microscope, broadly that's what you're looking for. Does everything look even and like it kind of fits, or is everything just a little bit abnormal? And that's something that you just get a picture of over time. Excuse me. So if we look at these images, I will begin to explain to you, hopefully you can appreciate that compared to what we saw before, where we had nice smooth outlines, nice regular spaced crypts, these are not quite the same. The image on the left-hand side, if you trust me and go on this journey with me, you can probably appreciate that the ones at the top of the image compared to the ones at the bottom of the image look different. Sometimes when you're looking at an image, you may not be able to articulate exactly why that's different. But what I will point out to you is that the ones at the very top of the image look a little bit fluffier in terms of their texture, a little bit darker, because the purple layer around the edge of these glands is thicker. And that's because when you look at it on higher power, the nuclei are more crowded, they are closer together, very packed, and that's a sign of dysplasia, of pre-malignancy. Whereas this image on the right-hand side, if you look at the internal lumina or opening of these crypts, it's not nice and circular like we saw before. It's actually pretty jagged and pretty raggedy looking. And that's a sign of hyperplasia. I don't expect you guys to know these things, but having someone explain them to you and point them out as normal or abnormal helps to build up your idea of what normal and abnormal look like, and some of the changes that we can see on histopathology that allow us to make a diagnosis, because it's a rich world and under the microscope. So bearing in mind what we've just been talking about things being regularly spaced, irregularly spaced, whether things look quite nice and smooth and their outlines are a little bit jagged and ragged. If you had to hazard a guess, would you say that this is broadly benign or malignant, or normal or abnormal? I'll give you a few seconds while I have a little drink. Now, I don't expect you to have a formal diagnosis for this because I don't either. But I can tell you that it's definitely not normal. In contrast to the image that we saw before, I've still got it on here, where these glands and these crypts are nice and ovoid and circular and regular and hanging down in a nice parallel fashion, this image is not showing that whatsoever. All of these white spaces, these pale spaces, are not the same size to each other. Some of them are a little bit pointed, some of them are a little bit twisted, and all of the cells that we saw before as nice little dark dots, these are all mixed and just irregular. And these are all things that you would want to flag up if you were thinking about malignancy. So this is an example of an adenocarcinoma in the colon, so the most common kind of cancer that you see in the colon. And how does histology fit into that? Well, I kind of got a little bit ahead of myself and answered that before. When we do colonoscopy and flag up that there are polyps or flag up that there are abnormal lesions, knowing what the histology shows allows us to stratify what happens to the patient next. If they have pre-malignant polyps or advanced polyps, then we may want to check them again much sooner than if they had a completely benign or normal colonoscopy. But it's the histology that helps to decide that. And this is why we work very closely with our surgical colleagues and our gastroenterology colleagues to help them strategize exactly what needs to be done with their patients. So case number 2, moving rapidly on. A 47-year-old lady is referred by an that's a typo, I apologize. Referred to by an out-of-hours GP to the acute medical unit with a history of nausea and epigastric pain. The GP referred her in with concerns of an acute MI. Reassuringly, her blood tests, including an amylase, come back in normal limits and her ECG is normal. When she's examined, she's tender in the epigastrium and has a history of the pain being worse at night. Recently, she started a new job and she's been struggling after the sudden passing of her father. What would the next appropriate investigation be? Now, this is quite reminiscent of your medical school finals and also some of your college examinations when you get to that point, in that these questions don't tend to ask you what the diagnosis is. They tend to ask you what to do about the diagnosis. The assumption is that you've already pieced the diagnosis together. So based on the information given, the most likely diagnosis for this patient, having burning within the chest with negative investigations and recently quite a lot of stress and pain that is worse at night, we're thinking about gastritis or some kind of reflux, gastroesophageal reflux type thing. And what is the investigation that's going to get us the best answer for that? It is an OGD, an esophagogastroduodenoscopy, and I promise you that not all of the answers here are all about endoscopy. But on endoscopy, these are the pictures that we see. So on the left-hand side, you can hopefully appreciate that alongside the regular normal pinkish mucosa, we've got these really sort of paler, grayer looking lesions. These are sites where a previous ulcer has likely existed and has begun to heal. And on the right-hand side, you can see that where the arrows are very helpfully pointing out, there are some bleeding points, which is likely either some telangiectasia or really small areas of ulceration. And endoscopists are very good. They can take us a sample, they can send it to us, and we can try to figure out exactly what's going on. And much in a similar way, the GI tract in the stomach is laid out the same way as that of the bowel, with a few minor differences. We still have our mucosa, our submucosa, our muscularis, and our serosa. But within our stomach, we don't need all of those crypts that hang down and dangle in, but we do need lots of glands that produce lots of substances to help digest and break down all of our food. and we need mucus-producing glands that help to protect the stomach itself. And we can see that better reflected on the right-hand side, where these very superficial or very close to the surface cells at the top of the screen are looking a little bit clear because they're distended full of mucus. And then this very thick layer just underneath of more purpley, pinky looking cells, they're the ones that are going to be secreting all of our enzymes and our hydrochloric acid before leading into our muscle. And broadly, if we're looking at these, the thing that we're going to be focusing on here is all of these little purple and black dots. These are lymphocytes. These are inflammatory cells. Broadly, what we can say between the slides on the left and the right-hand side is that there are a lot more blue-black dots on there. So there are a lot more lymphocytes, which means we have a lot more inflammation. And what are we going to do to investigate that? We are going to think about exactly what could be causing that inflammation. And if we go on to even higher power, trust me, you may find a few acute inflammatory cells in there like neutrophils. And this is where we get fancy with histopathology, because we can do a lot more than simply look at what we've cut up in the lab. If we have an inkling that there may be a diagnosis that we want to prove, then we can do additional staining on the tissue that's sent to us. So we can do immunohistochemistry, and we can use alternative stains on tissue to see what shows up, essentially. So if you remember earlier, I spoke about all the pinks and purples that we look at being conferred by the stains hematoxylin and eosin, or H&E, as everyone calls it day to day. You can do other stains, and you may have heard of some of these when you're going through your exam revision, when we talk about Zeal-Nielsen stains for tuberculosis or Congo red for amyloidosis. We can use those special stains that show up different structures in tissues. And we can also use immunohistochemistry to show up the individual cell receptors on a cell as an individual passport that tells us what it is. For example, certain skin cells would express markers that muscle cells wouldn't, that makes them uniquely muscle cells or skin cells. And we can use different receptor markers to tag them and show them up and see what they are. And that's basically what they end up looking like. So rather than it being a pink or purple or sort of whitish color, they can exist in these sort of really nice blues or browns, depending on what it is that we're staining for. And you have to interpret them in a little bit of context to know exactly what means a stain is positive and what means a stain is negative. But it allows us a greater insight into the tissue that we've got, and we can make it give us more answers than it wants to give us. So as one example, if we look at image B, that's a normal H&E stain. So that's the pink and the purple that we've been looking at so far. Whereas if we look down at C, you can see that it's a lot browner, a bit more gold. That's had a really good uptake of some kind of marker in comparison to image D, which is blue with only one little speck highlighted by that arrow. That's generally considered negative for our immunohistochemistry. Usually they show up as blues if they're browns if they're positive and blues if they're negative. But if we take a little look at this, we can see that we've got the sort of grey-blue ghosty outlines of our normal cells, the negative cells. And then we've had this really sort of strong uptake here of orangey brown in the centre. And I shouldn't have said that because I've just answered the question on the slide. But at least you know now. This is a stain for H. pylori, and this is showing up as positive. So there are little microorganisms on the surface of this piece of tissue and also deep within the crypts. And that is going to be causing all of this inflammation, adding to the gastritis that our patient is experiencing. So knowing this allows us to better strategize the treatment that this person can have. And that is exactly what we look like in the laboratory once we make that diagnosis every single time. So I'm moving on at a slightly rapider pace because I'm aware that we did start late and I don't want to take up too much of your evening. So I apologize if I'm going too fast for some of you. I just really want to make sure I get through everything that we need to. So moving on, we have case number 3. A 53-year-old man presenting to ED with generalized abdominal pain, fevers, and fecal vomiting on a background of not opening his bowels for 7 days and not passing any wind-off laters for 2. A CT scan shows free air in his abdomen, and he has a dilated colon with a transition point in the left side of the abdomen. When he's taken to theatre, a perforation is found in his descending colon, and the tissue is thickened around there with concerns that this may be resulting from a cancer. So he has a hemicolectomy performed and the specimen is sent to pathology. Now, whenever you get to your finals and you have questions like this, you may not understand absolutely everything in the question. Most people would not be aware of what a transition point is, for example. However, take from the question what you can to add to the diagnosis that you need. This is a gentleman that has had fecal and vomiting, not opened his bowels, and has not been passing flatus. So those are signs of progressive bowel obstruction, typically large bowel obstruction. CT scan showing free air. Obviously, we know at that point he's had a perforation. And a lot of these things are teeing up that this gentleman has had some kind of sinister cancer that has then gone on to obstruct him. So prior to actually getting things onto a slide under a microscope, we do have to go into the cut-up lab and actually look at these specimens, see what we think is going on at an eye level or at a macroscopic level, and then select little bits of tissue that we can then look at under a microscope. Now, I think there is the assumption that whatever specimen we receive in pathology, we just process the entire thing. But one of my colleagues once did this to a single uterus and generated 100 microscopy slides, bearing in mind the average for the number of slides is about 5 per case. That took quite a long time to go through and was quite unnecessary. So we do have to be a bit educated and a bit picky about what we take and what we look at under a microscope. It also means we do have to know a good bit of anatomy though. So on the left-hand side, you can hopefully appreciate that, bear in mind this person had a left hemicolectomy. This is basically what we'll have, or more or less what we'll have. We're going to have a little bit of transverse colon, some descending colon, potentially some sigmoid colon, probably not any rectum actually, but there's only so much I can do with one picture. And then imagine that on cutting open of this specimen, we see some normal bowel in this middle image on the left and the right-hand side, but then all of this very messed up, tortuous, thickened, ugly-looking stuff in the middle and on the right-hand side. And this is what cancer looks like. It disrupts and distorts normal architecture. And for this particular person, it's obviously caused an obstruction. So what we're looking for is an area that's strictured, that's narrowed down, or that we might not be able to pass any instruments or any, fingers through on examination. And this is the area that we're going to want to sample. So we tend to try and sample the tumour, obviously, but any adjacent areas that may look normal so we can compare the two together and see how distorted they are. And the Royal College of Pathologists is very good at giving you various different data sets, or basically tick box sheets, that tell you what you should take for what condition in order to make sure that you get all of the information you need to give the best possible answer in terms of a diagnosis, but also being able to prognosticate for this patient exactly how aggressive their cancer is and what treatment may be best for them in order to maximize their survival. So for the colorectal or the bowel cancer data set, for example, it would tell us that we need to take so many blocks of tumor, so many blocks of bowel adjacent to the tumor, so that we can check that the surgical resection is clear of disease. And we also need to make sure that we check the lymph nodes. So in the top right-hand side of the screen, you've got that normal bowel that we looked at in our first case, those test tubes hanging down, nice and regularly spaced, nice and even and equal. And at the bottom of the screen, we have 2 images of quite nasty cancer, essentially. We don't have nicely arranged glands. They're not nice, circular and evenly spaced. We say that they're quite angular, they're quite aggressive. And you can see that all around in this bottom left-hand picture, we've got some extending very deep into the tissue that are fully encapsulated by pink fibers. These are invasive. Our epithelial cells should only really exist on the surface on our epithelial layer. If they're seen deeper or invading, that's an aggressive sign that we have an aggressive invading cancer. And hopefully you can appreciate the contrast between the picture at the top and the picture at the bottom. We spoke before about those dark purple or blue or black dots being the lymphocytes and the epithelial cells. hopefully you can appreciate here that these are actually not very nicely arranged at all. They're very different sizes. The chromatin inside the nuclei is showing up in lots of different textures. Some are speckled, some are spotted. And this is very disorganized. The body tends to exist in a very orderly scenario, and this is very much the opposite of that. So as well as assessing the cancer, we have to look at the lymph nodes. And it's at this point that we have to question, okay, well, if we have a lymph node, why are we looking at a lymph node? We're looking at a lymph node to see if there's any evidence of metastasis, any disease spread that has gone to the lymph nodes. So in order for us to make that assessment, we have to know what a normal lymph node looks like. And on the left-hand side, this is what a normal lymph node looks like. If you chop it in half along its longest dimension and look at it under a microscope, this is what we see. We've got vessels entering it at the very center, branching out towards the purpley outside, which is just rich with immune cells and lymphocytes. Now, if we see that this is taken up by other tissue or other architecture, we then have to question why that is or where it's come from. And what we find is that actually this lymph node, if you imagine this is from our patient, this is actually taken up by these very angular nests of cells that have got very aggressive lumina and aggressive nuclei. And it looks quite a lot like the mass that we saw previously. And what does this mean? It means that our patient has a lymph node metastasis. And all of this information is super, super crucial to allow us to TNM stage this cancer and guide the treatment and prognosis. And you'll probably be familiar if you're thinking back to things like Duke's criteria that you may have encountered in your surgical rotations. It's important to be able to stage our cancers and know how invasive they are through the bowel wall. Now, for this particular patient, we saw earlier that they had some nests that were invading deep into the mucosa in this lower left-hand picture, encapsulated by pink substance, which is the muscle. And we've also said that they are likely that they do have some lymph node metastases. Now, if I tell you that our slides have shown that we've got a cancer essentially invading into the muscular layer, but not through it, and we've had 2 lymph nodes out of the total of 15 taken that have shown to have disease, it basically becomes just a case of finding on the staging criteria exactly where that correlates to. And what this means is that we have a T2 N1B colorectal cancer. This means that when it comes to discussing this patient at the MDT, we can talk to our oncological colleagues and our surgical colleagues about whether further treatment's needed and exactly what therapies are going to be best for this patient. So through a little bit of that work in the histology lab, we managed to optimize the patient outcome, improve their survival, and do a really good job, I've got to say. So what are the take homes that I want you to have from this? This has been a lovely whistle-stop tour through one really small area of histopathology, just hopefully getting across to you that so much of our job is visual, as well as really putting the theory into practice of the science, the anatomy, and the physiology of medicine. It's a full game sport to be able to take a specimen, pick out the key features, and make a diagnosis. But crucially, it relies on the work of everybody in the team. If I don't know where a sample has come from, or if I don't know exactly why they're sending a sample in, there's only so much information that I can give. And it's really important to be able to work with all of our colleagues in order to really improve the work of our patients. So if you guys have any questions, I will happily take any questions. The chat does seem to be a little bit quiet. If Stephanie has any questions that she wants to direct to me while I'm giving a talk, then I'm more than happy to take them now. Otherwise, I shall probably thank you for your time and let you get on with your evening.
I don't know if you can hear me, Aiden. It's Kyle.
Oh, hi, Kyle.
Sorry for the technical difficulties at the start of your talk. Thank you very much for giving yet another great talk for our histopathology webinar series. I'm getting familiar with this new Restream service, so if any questions do come our way, I'll be sure to direct them towards yourself. But in the meantime, what I shall also do is, for those of you in attendance, I will attach just a quick link to the Mind the Bleep webinar page, where you should hopefully be able to do a very simple feedback form, which will help both Aiden and ourselves at Mind the Bleep improve these talks for future. So I will just loiter around and then direct any questions your way, Aiden, if any come through.
Great, thank you very much. I shall hang around for a few minutes.
I think you may have stunned your audience into silence and been absolutely comprehensive with your talk, leaving them with all their pre-existing questions answered. So if you want, thank you for delivering that talk. Feel free to head off yourself, and I can loiter around and make sure that everybody's got a couple of extra minutes to fill in the feedback form. But yes, thank you very much, Aiden. Much appreciated.
Great, thank you very much for giving me your time. Oh,
we do have a question.
we
Any
do.
tips for applying to ST1?
Okay, grand. So I can give you some information towards that because I recently applied myself. So in terms of applying for ST1 at the moment, in terms of applications, applications are still running on a two-step process. So the first stage, which is the same for many specialties now, is to essentially score your portfolio and complete a self-assessment. Based on the self-assessment that you submit, there will be a cut-off score as to whether you are invited to interview or not. And the things inside that portfolio, the things inside that self-assessment include a lot of standard things that you will be doing as part of your general day-to-day medical work, such as clinical governance, making sure that you're doing an audit, fully cycling it and presenting it, teaching, whether you do that at a local level, a series level, or a national level if you're that lucky. But a big thing for histopathology is that they really want to see that you're making an informed decision to actually undertake histopathology. So my biggest pieces of advice would be to get in touch with your local friendly histopathologists in the pathology department to arrange a taster week of some form and make sure that everything you do is evidenced. So if you do go on a taster week, get an email or a short letter to confirm the dates that you've had your taster week and who you've undertaken it with and what you've done. I would say on that taster week, try and learn as much as you can, try and talk to people as much as you can, go into the cut-up room and see how we dissect specimens, come into the microscopy room and look at a few specimens and get your eye in for a few basic pathologies, and try and see a post-mortem if you can. Mainly because regardless of whether you want to do postmortems or not in your entire career, it is a mandatory part of the curriculum for at least the first 2 years. So I think it's really good to get a bit of understanding as to what the process is and what goes on. Personally, I love postmortems, but I know some people are not so keen on them. So those would be the main things I would say to get away from a taster week. If you can align any of your projects along histopathology, that's a bonus. I believe that for the criteria, they still say it should be something related to histopathology rather than purely about histopathology. So, for example, when I applied, I had some case presentations and case reports of some interesting conditions, and that was pathology related because it discussed a pathology, it discussed a disease. So even though most of my things were technically more surgical orientated, that overlap did exist. So maximize things on your CV as much as you can as well. Even though I didn't think I had much specific for histopathology, I did have a lot that I could use in my application. And that is the main bit of getting your foot in the door, I suppose. After that, it's the actual interview itself. And that is a multi-station process where they will ask you about various bits of your managerial and leadership skills, about times that you faced difficulty or had to make difficult decisions, along with assessing your clinical knowledge, where they'll give you broad situations about, how would you deal with a patient that had a shadow on their lung or an opacity on their chest x-ray. And they want to assess your understanding of differentials and managing a patient from that perspective. Now, there is zero requirement and zero expectation for you to be able to interpret any microscopy or histology during the interview. That's the whole reason why you're applying to the training program. If you could already do it, why would you be applying? But they do want to know that you have an understanding of disease and an understanding of how patients are worked up for disease, because we are one part of that entire process, a key part, but one part. So understanding the journey of how things get to you is important. But make sure you practice lots with your colleagues, make sure you practice lots with other applicants and get all the feedback that you can. It goes by very quick.
Thank you. Sounds like a very comprehensive answer. I'm a little bit long in the tooth these days in terms of applying to histopathology. But yes, I think I would echo Aiden's advice. It all sounds very sensible. The other thing to be aware of is keep your eye out for any further Mind the Bleep webinars in future and the resources online. We're hoping to maybe get a few more things up and running, some of which may pertain to applying to histopathology as well. Okay, any more questions?
I apologise if I've overwhelmed anybody. I just got very excited to talk about histology.
It's always good to have people passionate about the job. Okay, well, I don't think anything's jumping in at this moment. So, yes, if you're happy, thank you very much, Aiden. Much appreciated as always. And yes, thank you to everybody that's come and watched the talk today. Much appreciated.
Okay, thank you very much. Have a lovely evening.
Likewise, take care. And just before I head off, guys, if you can fill out the feedback form, it'd be really grateful for the team, just so we can help improve these webinars for future. So thank you very much all. Take care and have a nice evening.